I'm grateful to be here. In fact, I'd like to start with the greetings and gratitude. I journeyed here today from the territory of the Algonquin people, which is where I'm making my home with my partner. Um, and that's pretty new to us. We've lived on the West Coast and Coast Salish territory for about 6 years. Much of that has been spent on the traditional unceded and stolen lands of the Musqueam, Tsleil-Waututh, um, and Squamish nations, which I'm very grateful to be here for. And I think about every day and how it relates to my clinical practice and how it relates to how I was raised in society and how we are in this state. I have a white settler ancestry, English on my father's side and Irish, Scottish on my mother's, and was born in Treaty 6 territory. So I was there for much of my life before I moved. And much of my work now, especially since being more immersed in substance use medicine over the last 6 years, I'm a family physician and substance use consultant, is really understanding how coloniality has affected myself and my community, ongoing racism, what anti-racism looks like, cultural safety and humility, and a trauma-informed practice, but also going beyond that and how do we heal wounds of trauma. And I'm a learner in all of these fields, as I am eternally in substance use medicine, always learning from my wonderful colleagues who are here on the call, some of the hub team, but also the many people who are attending from all over the province and further afield. We're so grateful to have you here. We're going to have a case discussion later on and some opportunities to talk about managed alcohol in general. So I think that's going to be the richest part, but I'm going to go through some of these intended learning outcomes. Thankfully, a lot of what I'm going to say is elaborated on in the guideline document on managed alcohol programs, which is going to be referenced at the end, and you shouldn't have too much trouble finding it. It's a collaboration between BCCSU, CSIR, many people have lived in living experiences, and I'm missing someone there. Sorry about that. So we're going to summarize the goals and objectives of managed alcohol programs as we know them, discuss the benefits beyond alcohol consumption change, and including social determinants of health, identify how MAPS, as we often shorten them to, may interact with other elements on the alcohol use disorder continuum of care, and how we support clients' goals, and also describing the types of MAPS in operation and identify when they might be appropriate for someone you may be working with or yourself. This is a pictorial diagram of conception of the alcohol use disorder continuum of care. Many of us are familiar with brief screening and intervention. There are some useful tools that we can use in a clinical space to bring up, start that conversation about screening for someone who might be having difficulties with alcohol use and then moving on towards a diagnosis of alcohol use disorder. There are many of us think of alcohol withdrawal management as a pillar of the care and treatment in alcohol use disorder, but it's only one of many. And there are the pharmacological and psychosocial interventions that we might be able to do either ourselves or in our team. And outside, we can see that it's connected with many other conditions from, we need to think about the person in their holistic context, working with the First Nations Health Authority and having received different teachings on wellness. I often am inspired by the medicine wheel, thinking about spiritual, mental, emotional, and physical well-being, which is much of what we see here, and notably chronic pain management, culture-based interventions, housing, community supports, and harm reduction, which is where we see managed alcohol programs falling. So background, sadly, the situation that we are seeing across the country is that many services are refused to people who are intoxicated or having alcohol on their person. And that current treatment options don't address the needs of many people with severe alcohol use disorder. And a reduction or cessation of alcohol are not necessarily the desired goals for somebody at one given point in time, and that there are limited low barrier services for people with severe alcohol use disorder. And those who do not have access to treatment or harm reduction are at risk of serious alcohol-related harms, such as alcohol poisoning, severe withdrawal, injury, violence from the medical system. A little bit about housing instability and alcohol use disorder. We see many people being refused shelter and access to services due to alcohol use. This is very closely connected to higher risk of hospitalization. And I like thinking about hospitalization as a risk because many people we work with experience violence and other harms in the hospital system. And we need to take that into consideration when we're working with somebody, especially if we appear as clinicians. If we're not careful, we can repeat some of those harms that people have experienced so often. But also incarceration and other harms are possible. That cycle reinforces housing instability and unpredictable access to services, and really the alcohol use disorder remains unmanaged. So non-beverage alcohol is something that many people think of in relation to managed alcohol disorder, and certainly we can see a decrease in non-beverage alcohol, but it is only one of many goals and potential outcomes of the managed alcohol program. So when someone doesn't have access through location or finances to their regular beverages of choice, they might use non-beverage alcohols, such as hand sanitizer, mouthwash, hairspray, to avoid alcohol withdrawal. And these can be associated with very severe harms from acute kidney injuries, neurological disorders, gastrointestinal disturbances we see, hyperactive autonomic nervous system, and cardiac and respiratory failure. So MAPs are generally thought of as low barrier harm reduction interventions on the continuum of care. And perhaps this is the first time you've thought about them on the continuum of care. And a lot of what we're going to talk about is how it fits in. Many people are not in a place where they can really see themselves reducing alcohol use. There could be many reasons from various types of pain and suffering that people are afraid of being exacerbated if they stop drinking, or their social circumstance might be such that it's not possible. In managed alcohol programs, generally people have tailored doses for themselves, and they are often integrated into a range of health and psychosocial supports. Some of the goals and objectives we see are the reduction of non-beverage alcohol, as we've talked about, reduction of severe withdrawal symptoms and alcohol poisoning, other harms such as liver disease, poor mental health, and physical injury. We might be able to stop the cycle of marginalization and survival drinking. I like to think of marginalization as an active process that society is pushing people to the margins. It's not a state of being inherent in any group. So we continually are doing this to our community members. So this is a way to bring people in to circles and spaces, and also break down some of the desperation and desperate circumstances that people might find themselves in. And when we co-locate or not, or have people knowledgeable in referral pathways, whether it's peers or others, we can make those referrals and connections that we might not be able to when people are not connected to the community. Key benefits. So we're referencing 6 different papers here. Housing stability, quality of life, and safety are greatly improved. This is generally found across the board. When I started my substance use journey and studied for the international exam, there was very little written on, relative to today, very little written on managed alcohol programs. There has been a huge blossoming of research in this area. The CMAPS has been a huge lead and partner in this endeavor, and it's wonderful to see so many thoughtful research projects, especially ones that are directly collaborating with people with lived and living experience, either led by them or closely done together. Other things that we can find that are clear benefits are reduction in alcohol-related harms, reduction of non-beverage alcohol use, emergency service utilization and hospitalization, and contact with police. Social determinants of health are may be hugely impacted by a managed alcohol program, depending on what kind, from financial management services to wraparound care with primary care, psychology, nutrition support, social services, connection and sense of community. And food and shelter are often tied into a MAP program, depending on what kind. These are 5 common and less common types of MAP programs. They are not the only ones, and many are overlapping. That's the intersecting circles here. So we have our peer-led drop-in models that might also incorporate outreach to deliver alcohol to individuals, drop-in and day program models, clinician outreach models at housing facilities and shelters, housing-based models, and inpatient care settings. The key thing here is that any one of you that might be involved in designing these is to think about the needs of the people and the community that you're serving and your local situation and circumstances. That's going to guide, I would suggest, be the biggest guide to what kind of program you have forward, and thinking about, I must say, the harms of colonialism, racism, ongoing undiagnosed trauma, and under-treated mental health disorders. A little bit about peer drop-in models, developed and operated by peers, offers members managed alcohol in a safer environment, and can promote a lot of autonomy, which is wonderful, self-efficacy, and a sense of community. These tend to be some of the lowest barrier ones. Some of the challenges that they're not open 24 hours a day, and there's often, by description here, no housing component. Some clients may not thrive in these if they have mobility that has been impaired, for example, or if the site is, again, linking to mobility too far. Next, please. Drop-in and day program models provide clients with managed alcohol and access to health and psychosocial services, may operate as standalone facilities or be co-located. And they can provide clinical care in a safe place. And again, we don't want to assume safe space. That's going to be different everywhere you are, and each individual needs to, working in these programs, needs to think about how they can be safe with people from all the different backgrounds that they're serving. Some of the program limitations are the hours in this kind, and again, no housing. And as we've seen and talked about, homelessness and housing insecurity is often associated with some of these cycles that we've associated with severe alcohol use disorder. Clinician outreach models. So we saw more of these come up at the start of the COVID-19 pandemic. More of an outreach model where someone could be located in perhaps a building dedicated to this kind of outreach, or a scattered site, different kinds of perhaps a few rooms within a building, where there would be a clinician assessing the needs and then a way to deliver the alcohol so that somebody can safely isolate. That was kind of the original idea. I think these can still have a lot of merit in different circumstances too, especially when there are mobility difficulties for an individual. They may or may not have a larger team-based way to deliver care. Really depends on how they're designed. Thank you. Then we have the housing-based models. These are perhaps the one that most think about. It's the one that I've been involved with the most, both in Saskatchewan Treaty 6 territory and out here in Coast Salish territory. These aim to break that cycle of homelessness and housing insecurity, and clients in these programs are housed on site. And there is continuous case management and psychosocial supports and services. Often food is a part of this program. In fact, in all the ones I'm aware of, food is a part of it. Admission criteria might be a barrier for some clients, and the funding and resources are certainly higher and might make it more challenging to implement this model. Then we have the inpatient care model. So clients in hospital or long-term care settings, such as somebody who's no longer able to see to their own medical needs, living in long-term care or nursing home, we sometimes call them. what we see here is that these kinds of programs and can promote autonomy and I think destigmatize using alcohol in acute care. One thing we would like to see more of is that that continuum or that journey can continue on into a MAP program into the community if that's helpful, which is not always possible. This has taken a lot of advocacy to have it included in some hospital formularies so that clients can actually be delivered alcohol while they're, say, recovering from pneumonia or a fracture. As of yet, in the community pharmacy-based alcohol deliverance is not active, but I would love for somebody to correct me if we're close or if we've already started doing that. Implementing. I think this is the most important part, is that you think about a managed alcohol program with the attitude of collaboration and humility, that this is something that many people could potentially benefit from, and it will be a more stable and acceptable program the more we work together with our community. Stakeholder consultation is of course key, and I would go further to say collaborating actively and constantly seeking feedback and contributions. Everyone is going to develop their own kinds of programs and policies. Model selection and design is going to be based on your local circumstance and the location and space. There are a lot of considerations. A greater discussion on these can all be found in the manual for managed alcohol programs. Alcohol storage and security are considerations, which generally there's always a solution. We want to think about staff training and qualifications. Some of the things we've mentioned earlier, such as trauma-informed care, anti-Indigenous racism and cultural safety and humility training, anti-racist training, harm reduction training and understanding. These are also not one and done type things, but things that many of us are on journeys to learn and should be revisited and reconsidered regularly. We might have differences in the roles and responsibilities of our team, again, depending on how big your team is. And then the funding and procurement of alcohol is often a consideration, and I really look forward to the case discussion around this. So in summary, MAPs are a harm reduction intervention that have emerged. They've been growing faster and faster, from only a few in the 90s to dozens of programs. And they're responding to the gap in the continuum of care for people who cannot or do not want to reduce their alcohol use, but struggle with alcohol use disorder. There are a number of benefits beyond stabilizing alcohol use and reducing survival drinking to social connection to food, shelter, and wraparound care. Some of the main goals are to facilitate safer drinking and offering tailored doses of alcohol, and to connect with people with wraparound supports and services. And there are many types that can meet people where they're at. And when we're planning these, the aspects of operations that should be planned should be specific to your client and your community that you're working with. I'm seeing some questions on the side here, specifically about OAT and OUD, and I can address that. Let's just maybe flag that. Is there, and these are, okay, so we're getting towards the end of this part of the presentation. These are the references we've principally drawn from. I really encourage you to take a look at those. If we could even go back, and if someone wants to screenshot those, so they maybe they can find the time to go through a few of these to stimulate some more thinking. Perhaps you're on your journey to developing one in your own community.